my respected teachers, distinguished faculties from home and abroad, and my dear colleagues and the ENT resident, I welcome you all to my session, and I must give thanks to the organizer, especially Khurshad Alam Majumdar sir, for giving me the opportunity to present this topic. My topic is how obstructive sleep apnea presents to me, that is the clinical feature. And this is my institute where I am working. At first, I would like to start with the symptoms and then sign. Symptoms are divided into two parts, nocturnal symptom and daytime symptom. Nocturnal symptoms included snoring, witnessed apnea, dyspnea, that is expressed by choking or gasping, drooling, dry mouth, bruxism, restless sleep, gastroesophageal reflux, and nocturia. And the daytime symptoms include excessive daytime sleepiness, that is EDS, morning headache, neurocognitive impairment, and they show vigilance, executive functioning, and motor coordination. Diminished quality of life, mood and personality change, and sexual dysfunction. Snoring. Snoring is the most frequently reported symptom. It is found in approximately 70 to 95% of such patients. Typically, snoring may have been present for many years. Intensity increases with time. It's exacerbated by nighttime alcohol consumption, weight gain, sedative medication, sleep deprivation, and supine position. Sometimes snoring is too loud to disturb the bed partner, and often it's a source of relationship discord. Sometimes patients slept in a different room from their partners. One patient gave me history that he took separate room for sleep. Brief gasp alternating with 20 to 30 seconds periods of silence, that is the apneic attack. Snoring is a poor indicator of obstructive sleep apnea syndrome because snoring is so common in general population. A snoring patient may not present with obstructive sleep apnea, and we should evaluate. Only 6% of patients with obstructive sleep apnea hypopnea syndrome don't report snoring. Approximately 75% of patients deny snoring are found to snore during objective measurement. Even you show a video recording to him or her, but she denied that I am not snoring at night. You give me false information. And witnessed apnea means bed partners report about choking or gasping. And sometimes bed partners get frightened that my partner may fall into death. Second most common nocturnal symptom, and it's observed by the bed partners. Cyanosis, frequent and violent body movement can occur in severe cases. And sometimes bed partner get frequent frightening. Patients are rarely aware of the APNEA, vocalization, frequent arousal, movement, or brief awakening. Elderly are sensitive to the frequent nocturnal awakenings and report insomnia and unrefreshing sleep. Now, nocturnal dyspnea. Sensation of choking or suffocating occur with arousal, associated with feeling of panic and anxiety, and generally subside within a few seconds. Mechanism of dyspnea in a OSA patient attacked by apnea or hypopnea and then increases his respiratory effort to overcome it, and it increases the intrathoracic pressure, and it increases the venous return to the heart, and subsequently pulmonary capillary pressure increase and patient felt dyspnea. Gastroesophageal reflux. OSA is a causal factor of nocturnal GERD. Prevalence rate is 64 to 73%. Most of the OSA patients suffer from obesity, and obese patients has more fat, and it acts as a bile divert, and it helps to release the stomach acid to the respiratory tract. What is the mechanism of GERD? Upper airway obstruction, increased intra-abdominal pressure, more negative intrathoracic pressure, and increased transdiaphragmatic pressure, and it produces gastroesophageal reflux. And we ENT people call it laryngopharyngeal reflux, LPR. Nocturia. Nocturia is found in 28% of patients with OSA. 4 to 7 episodes per night. You think if you awake 4 to 7 times and go to the toilet to evacuate your urinary bladder, and sleep becomes fragmented. Presence and frequency of nocturia indicates the severity of OSA. If there is nocturia, you think that the patient suffers from severe disease. Increased atrial natriuretic peptide secretion and or increased intra-abdominal pressure, increased total urine output. We know during sleep, all the hormones become low except antidiuretic hormone and growth hormone. If the sleep becomes fragmented, antidiuretic hormone release becomes less, and it causes more and more urine output. Majority of nocturnal awakenings actually due to sleep-related phenomena. Patients get awakes and voluntarily urinates with each arousal. Sometimes. Daytime symptoms are less specific as they can result from abnormal sleep of any cause. If you get deprivation of sleep due to any cause, you may get daytime symptom. Excessive daytime sleepiness is the most common daytime complaint in patients with OSA. Only this symptom is a poor predictor of OSA because sleep deprivation by any cause may produce EDS. EDS is caused by sleep fragmentation leading to frequent arousal and insufficient sleep, manifested by inappropriate urge to sleep, particularly during relaxing sedentary activities like watching television and reading. Inability to control sleepiness can result in dozing during meeting, active conversation, and at mealtime. Sometimes OSA patients get sleep during meal. When severe, EDS can be cause of motor vehicle accident, machinery accident, poor school performance, and relationship discord. Here, all the people are awake during morning meeting, but do get sleep during morning meeting. So, OSA is a cause of maybe chance of loss of job. Now, Epworth sleepiness scale. Epworth sleepiness scale is so popular that we know that Epworth may be a medical scientist, and by his name the scale is named, but no. Epworth is a hospital, sleep center in Australia. We know Epworth sleepiness scale, but the inventor of this Epworth sleepiness scale, Dr. Murray Jones, we forgotten. Dr. Murray Jones, he invented the Epworth sleepiness scale. Murray Jones developed Epworth sleepiness scale so he could assess the daytime sleepiness of the patients in his own private practice of sleep medicine. The questionnaire is named after Epworth Hospital in Melbourne, where he established the Epworth Sleep Center in 1988. Simple self-administered questionnaire that is a quick and inexpensive tool with a high test-retest reliability and is thus a practical means of measuring the general level of daytime sleepiness. It also disadvantages. The major disadvantage of the Epworth sleepiness scale is its reliance on subjective reporting by patients who may underestimate or intentionally underreport severity of daytime sleepiness. He may suffer from malingering and take the benefit because it's a subjective assessment, not objective assessment. This is the Epworth sleepiness scale, and it contains 8 questions, and each questions carry 0 to 3 score, and here is the grading of excessive daytime sleepiness. And other questionnaire also: sleep disorder questionnaire, Berlin questionnaire, Stop Bank questionnaire, OSA 50 questionnaire, self-efficacy in sleep apnea questionnaire, and Calgary sleep apnea quality of life index. Morning headache: those slept whole night but suffered from morning headache. Morning headache are reported in about half of patients with OSA, are typically dull and generalized, last 1 to 2 hours, and may require analgesic. What are the causes of morning headache? Nocturnal episodes of oxygen desaturation, hypercapnia, cerebral vasodilation with resultant raised intracranial pressure, impaired sleep quality, polysomnographic evidence of decreased total sleep time and sleep efficiency. Neurocognitive impairment revealed by executive functioning, motor incoordination, diminished concentration to memory, short and long term, intellectual deterioration, vigilance. Psychomotor impairment appears to be largely related to hypoxemia, and hypoxemia produces anoxia to the brain and causes the brain damage. Mood disorder, depression. Depression is the most common mood and personality disorder. Anxiety, irritability, aggression, emotional lability, restlessness, laziness, and shortness of temper. Treatment with CPAP has been shown to ameliorate symptoms of depression, and therapy improves quality of life in some patients. Sexual dysfunction. Sexual dysfunction manifested primarily as erectile dysfunction and decreased libido, impotency associated with OSA, and appear to be fully reversible with treatment. And now sign: blood pressure, body mass index, obesity, neck circumference, and examination including the upper airway, that is craniofacial abnormality, examination of the pharyngeal structure, abnormalities of dentition, examination of the nose. Blood pressure. Hypertension is common due to nighttime catecholamine secretion following frequent arousal, but patient may present with hypotension. Many population-based studies have shown that hypertension is independently associated with sleep disorder breathing. A hypertensive patient may take several medicines to control his blood pressure, but after treatment, the dose becomes less, reported by the patient to our daily practice. Improvement in hypertension with sleep apnea treatment. So, OSA is a positive factor for hypertension. Obesity and BMI. Obesity is frequently associated with OSA. Body mass index 25 kg per meter square associated with 93% OSA. 18 to 40% affected patients are less than 20% above the ideal body weight. Now, neck circumference. Which neck circumference we measure at the level of the thyroid membrane in sitting position. At the level of the thyroid membrane, we should measure the neck circumference. Increased neck circumference is more reliable clinical predictor of OSA. Patients with OSA had an increased mean neck circumference. Neck circumference 40 cm indicates severe OSA. Neck circumference should be routinely measured during physical examination, and if more than 40 cm, underlying OSA must be considered and must be investigated. Now, examination of the upper airway to identify the potential areas of airway narrowing and as well as to guide the therapist. The hallmark of OSA is crowded upper airway, which is manifested by various characteristic morphological abnormalities of the craniofacial, pharyngeal, dental, and nasal anatomy. Retrognathia or mandibular retroposition, most common cranial abnormality associated with OSA. How retrognathia produces OSA? There is delayed growth problem. Delayed growth of the mandible, maxilla, or both, and produces retrognathia, and posterior displacement of the tongue base and narrowing the upper airway in the retroglossal region. Now, highest palate. Patients with sleep disordered breathing are commonly found to have highest palate. Palpation of the temporomandibular joint with mouth opening may reveal varying degrees of dislocation. Produces airway collapse in supine patient due to posterior displacement of the TM joint. Examination of the pharyngeal structures. Macroglossia often associated with lateral lingual escalloping by adjacent teeth. Sometimes patient told me that I have many impression in the lateral margin of the tongue, please give me treatment. I am suffering from cancer phobia. The lateral escalloping of the tongue indicates the macroglossia. Sometimes normal patient present us with this symptom. That is the escalloping, that is the dental impression. Erythema and edema of the uvula due to snoring. Redundant lateral wall soft tissue with tonsillopilar hypertrophy. Tonsillar enlargement graded with 0 to 4 scale, which is a particularly significant cause of obstruction in the children. Tonsillar size grading. Tonsil size 0 means tonsillectomy, that is grade 0, and tonsil size 1 means within the pillars. This is within the pillars, tonsil are within the pillars, grade 1, and tonsil size 2 means extend to the pillars, that is the grade 2, and this is grade 3, extended past to the pillars, and tonsil size 4 extend to the midline. Many of our ENT colleagues told that this is kissing tonsil. It is in the midline. This is tonsil size 4. Friedman is a renowned sleep surgeon. We ENT people oftenly called the Friedman tongue position. Previously it is known as Mallampati score. Oropharyngeal crowding can be characterized by the Friedman tongue position. Visual assessment, size, length, height of the soft palate and uvula. These structures represent the entry limit of the upper airway. Friedman tongue position is an independent predictor of both the presence and severity of OSA. World standard in the pharyngeal evaluation remains direct laryngoscopy, as it is the most reliable means of identifying the actual aesthetic and dynamic restriction of the retroglossal, retropalatal space, which are common sites of obstruction. This is the Friedman tongue position. Friedman tongue position, interuvula, tonsil and pillars are visualized. Friedman tongue position 1. Friedman tongue position 2A, most of the uvula but the tonsil pillars are absent. Friedman tongue position 2B, intersoft palate to the base of the uvula are visualized. Friedman tongue position 3, some of the soft tissue, soft palate is visualized but distal structures are absent. That is the Friedman tongue position 3. Friedman tongue position 4, hard palate only you can see, hard palate. Abnormalities of dentition often observed in patients with sleep disorder breathing and typically reflective of maxillomandibular deficiency, and airway crowding. Patients with these physical features will frequently report previous wisdom teeth extraction and childhood orthodontia. Dental overjet is a common sign of underlying mandibular retroposition and refers to forward extrusion of the upper incisors and beyond the lower incisors more than 2 mm. When we bite, the upper incisor is front and back lower incisor, and in dental overjet there is gapping more than 2.2 mm. Findings of dental malocclusion and overlapping teeth indicate a restricted oral cavity that is prone to collapse. And examination of the nose is the last important component of the upper airway evaluation. Nasal obstruction is rarely the sole cause of sleep disordered breathing. Nasal obstruction is frequently found in OSA. Nasal obstruction increases the upper airway resistance. Nasal obstruction in children may cause chronic mouth breathing and secondarily results in craniofacial maldevelopment. Now, inspection of the nose, size and symmetry of the nares, collapsibility of the internal valves, external valves, and nasal alley with inspiration, evidence of septal deviation or prior nasal trauma and hypertrophied infraturbinate. There is bilateral collapse of the nasal rim is frequently observed during inspiration in patients with OSA associated with nasal resistance, because more intrathoracic pressure affects the nasal valve to collapse. When we took green coconut water frequently and by force, you take the green coconut water by force with a straw become collapse due to more negative pressure within the oral cavity. And here is the same mechanism, more intrathoracic pressure produces nasal rim collapse. Common physical findings in a nutshell in patients with OSA: craniofacial features like retrognathia, high-arch palate, and TM joint dislocation. Pharyngeal features: macroglossia, erythema and edema of the uvula, elongated low-lying soft palate, tonsillopilar hypertrophy, tonsillar enlargement, retropalatal retroglossal space restriction. Dental features: overjet, malocclusion, bruxism, orthodontia. Nasal features: asymmetric small nares, inspiratory collapse of the alley and internal valves, septal deviation, and infraturbinate hypertrophy. Thank you, everybody.